This is our third panel now, and this is on, actually interoperability has come up in a few ways with regard to electronic interoperability or other sorts of relationships and communications that can make some of these issues work, whether it was with our social determinants of health issue, as well as advancing advanced care models and so forth. This whole notion of coordination, data and information exchange and availability is essential, and therefore we have as our title here, Interoperability, Key for Success in Coordinating Quality Care. One of the very interesting things I found out about all three of our panelists is that they kind of all do cool stuff. I had not known about any of these three organizations, and even when I started looking into them, I thought, gosh, that's something I never would have thought of even doing. So they have come in sort of in innovative ways to fill certain market niches subject to new demands that had not occurred to me in any case. So with that, I want to ask each of our panelists to introduce himself, name, organization, and what kind of interesting thing you do that's meeting a need or a demand in the healthcare system, starting with Taylor.
Yeah, so my name's Taylor Justice from Unite Us, and we are a technology platform doing care coordination, but for non-clinical service providers. So in the world of social determinants of health, we are providing infrastructure that allows housing, transportation, employment, legal, finance to coordinate care around shared clients or patients and then connect them into the health setting. And so this infrastructure goes all the way towards the end where and what I mean by that is answering the question, can I prove that my patient or client has received the services that they're looking for? When I look at the healthcare space, we do a lot on the front end of our work, meaning we screen and we identify the social determinants of health. Not many people are actually addressing the social determinants of health. And how do you get these community-based organizations to the table to adopt a technology system that's outside of the four walls of their organization, but allows them to collaborate with other community providers? And so we started off in the veteran and military space, have transitioned now to be population and service provider agnostic, and we have 38 coordinated networks across the country that are all connected to each other. So one patient record across this transient population.
See, this is a cool thing that I didn't realize before. If you were in our first panel, you heard Carter Wilson say that he has to operate across 16 domains. And none of those domains were really set up very well to communicate with the other 15.
Right.
And lo and behold, Taylor Justice comes along with Unite Us and says, well, maybe we can set up an electronic platform to do just that. So again, filling a new market niche. Very important and helpful. Arien, what do you have at Change Healthcare?
Great. So I'm Arien Malec. I'm the SVP of R&D for Change Healthcare. Change Healthcare is the combination of the technology assets in McKesson and except for the EHRs, as well as the technology assets of what was then Change Healthcare, which was sort of ex-Amdion. And I run the clearinghouse for a good chunk of the country. For medical claims, eligibility, remittance, and increasingly we're helping the organizations we work with to use that data to improve the cost and quality of care and drive efficiency of care delivery and administrative processes. I also have a sideline gig in health IT policy. I served in the ONC trying to drive the direct project to enable information exchange between providers, as well as a broad portfolio of interoperability initiatives there. When I went back into the private sector, I also kicked off the Commonwealth Health Alliance, partnership of EHR vendors to drive interoperability built into the EHR technologies, as well as participated in the Argonaut project, helped to get that thing off the ground and co-fund it. And the Argonaut project, if you saw the Apple Health announcement, the ability for an Apple device to reach out into now 40 health systems and pull back records into Apple Health. The underlying standards there were standards that were developed through the Argonaut project.
can't let you go without a few things. First, the ONC, the Office of the National Coordinator,
Yep.
which was a federal office, obviously. Interoperability has been one of their watchwords since the very, very beginning. They haven't quite conquered it yet, but on their way.
Any day soon.
Yes. Apple, I did not know, reaches into 40 health systems.
Yep. So if you actually go to your Apple Health app, and I encourage you to do this, if you go to your Apple Health app, there's the ability to get your health record, and there's a whole long laundry list of systems. Apple does a nice job of using your location data to figure out the systems that are close to you, and it's really just one push, and you have to log into effectively your portal credentials, and it just pulls down your records, and there they are in Apple Health, accessible to any of the apps that plug in there. So it's a really fascinating way of taking health data in the same way that historically we've done, for example, famously Mint.com that was acquired by Intuit did this. And one of the funny things is back in January 2010, a bunch of us were at a think tank, the Merkel Connecting for Health consumer engagement work group, and Adam Bosworth said, well, if only we just had a big blue button to download your health records, we could do a bunch of amazing things. And 8 years later, here we are. So the wheels of interoperability move slowly, but inexorably.
Indeed, gosh. Wow. Edwin?
I'm Edwin Miller. I'm one of the co-founders of Aledade. I'm also the Chief Technology Officer. My background was building health IT products in various parts of healthcare. Aledade creates and operates ACOs around primary care physicians. So our belief is that primary care docs can be the foundation of an effective and high quality healthcare system. And so we help independent docs make the transition to value-based care, which is a very daunting task for them. If they're still independent in the year 2018, they want to be independent and they want to learn how to make this transition. My background's working on dozens of health IT products over time, mostly EMRs, mostly in the ambulatory space. And coming to Aledade or starting Aledade was really kind of having to eat all the dog food now that I moved from the vendor side to to having to go now consume the data that was generated by these systems, and which was definitely an unpleasant surprise.
Well, I was about to ask you how the dog food tastes. What did you, but more seriously, what did you actually learn from eating that stuff?
Yeah, well, we learned how low quality the data is, and we learned about, and so our other co-founder is Farzad Mostashari, who is the coordinator of Health IT, and Matt Kendall as well, who ran the REC program within ONC, which was the Regional Extension Center to help people get to meaningful use. And so, we have this background of, knowing a little bit about the EHR space and kind of what our expectations were, and I can say our expectations of what was going to be available from the typical EHR vendor was not met, certainly in the real world.
And therefore, the take-home lesson from that is what? I have to seize on it now because this is the bugaboo. This is like, oh, wouldn't it be great if? And then when you actually look at them, it doesn't mesh so well. So what's our take-home message going forward? As you've been on both sides.
So I frame it like this. I have like a 2x2 in my head where one axis is the availability of actionable information, and the other axis is incentives. And so when you have high incentives and no information, then you have heroics where doctors are trying to participate in P4P programs and they're doing manual sharp pulls and getting data by hook or by crook. When you have no incentive but actionable data, you have kind of the EHR meaningful use program, which is basically box checking, right? So like, I have an EHR, great, box checked. I can show that I can interoperate with somebody one time to attest for me if you use check. And so in the ideal quadrant, you want to have high incentives and actionable data, which is where you can actually now have a why for how that data can be made useful for patient care. And so that is where we are headed with, in these conversations today, and certainly where Aledade lives. But before that, it was basically people had EHRs and they didn't have really a reason why to know how good the data was, or to drive their workflow in a way that would capture the data in the right way, or even know how it works in their EHR, as well as the straight up, the EHR vendors, the software is pretty clunky in this regard.
Got it, okay. Very interesting. So in your way, you're all about making ACOs work for primary care docs, right?
Yeah, for independent docs that are not,
So
and
that's your important niche then as well.
yeah, absolutely. And it's sort of like a little bit of Moneyball. They're sort of like the undervalued players in the healthcare system. They account for 4% of the cost, but they can influence, 85% of it. And if they have the incentives to make better decisions and take risk, which is where we're headed, they can be very effective at this.
Moneyball for doctors.
Yeah, and then get an increased share of the value that they're creating by doing those things.
Point well, that's great. So this session is about interoperability for coordinating care, and I want to sort of catch up, maybe start with Taylor. Catch us up on what means today, 2018, interoperability, perhaps as opposed to what we were thinking about when the first ONC took office.
Yeah, so my world, I look at community-based organizations first. And how they connect to each other. And if you look at human and social service providers, they are historically behind the bell curve when you think about technology, which is actually a strategic advantage, because now we can leapfrog and get ahead of, old architecture. And so when we think about interoperability and we talk to healthcare clients, they are trying to solve the same problem that 211 systems were trying to solve in 1996. How do I get this great resource directory of services within my community? And I'm going to define referral as I'm giving referral to the patient and hoping that they go find what they're looking for. Again, no outcomes. When we think about interoperability, it's the same thing within a healthcare setting. The system of record for most health systems will be the EHR. Within these community-based organizations, they're going to all have their own siloed system. And so what we are trying to do is connect into their existing infrastructure. So I might have a nonprofit organization that's taking advantage of 10 free Salesforce licenses, because again, it's free from the Salesforce Foundation. I'm not going to be able to replace that, and I shouldn't. I'll connect into it. So we've done an integration there. We connect into these 211 systems, either their telephony or their INR, so that they can make now direct referrals to community providers. We connect into EHRs, Epic, Cerners, and other systems. So we want to be this mesh of everything that's happening outside of your four walls. And connect into those systems where it's then seamless. Everyone is, again, trying to look at the answer or solve the wrong problem. And what the problem we're trying to solve is, again, that last mile. Can I prove that I've connected this patient or this client to the services that they need? So we think about the existing infrastructure and how can we plug into it rather than replace it.
Taylor, forgive me for asking, are you software and or are you hardware, or what are you?
Yeah, good question. We are purely a software organization, but we might as well be a change management organization, because we have to go into each of these community-based organizations and create value for them, which most, and no offense to anybody in the room, healthcare doesn't think about. And so we have to go in and say, okay, how can I create value for you or help you operate more efficiently? Because more often than not, these organizations are understaffed, underfunded, and we're looking for ways to reduce that administrative time that they're spending on manual work, phone calls, emails, Google searches. And we're reducing administrative times by like 86% in some of these organizations.
Does your software enter their operating environment?
Yes.
Or it does?
It does. So it goes in line with Salesforce, so they don't think that they're even leaving Salesforce. Same thing with Epic, where most integrations, you'll require the Epic user to go into a second system, although the data is transferring on the back end. What we're doing is in line with Epic, so the Epic user doesn't even know they're leaving. And so you can say, yes, we're capturing social determinants of health information, but that is still dependent within a clinical setting on that clinical provider actually hand jamming it in. And what we're trying to do is, what if I could pull that information into the EHR, which is the system of record, and have it there, but the community is doing the work that they're already doing.
So is the EHR still this kind of central node here?
For healthcare,
For healthcare it is.
but not for the community providers. Because if I'm trying to address the social determinants of health,
Right.
I need to work with those community-based organizations, housing, education, employment, legal. If I'm making a referral to them, how do I know that that organization can accept it? So we have to map their programs, their eligibility requirements down to the people that run them. Because it's not a referral to an organization or a black hole, contact me at icanhelpyou.org. It is, I'm connecting Taylor to Sue. And now Sue's taking positive control of that referral, going to take that person through a process out to an outcome, and then that can get relayed back into the EHR or whatever your system of record is.
Got it. Never would have thought of it. Sounds like a great idea. It sounds like you're making it happen. Good gosh. Arien?
Yeah.
So how has the concept of interoperability changed? You're in a great position to judge that because you were kind of close to the beginning on that anyway.
So I've learned to start thinking about 3 to 6 year cycles, which is incredibly disappointing because my constitution's more of a technology innovator, internet person. So ONC started, I think, in 2003 as an administrative organization. And then was instantiated in 2009 as a permanent office. In 2003, the policy goal was around getting a view of a patient record to clinicians at point of care.
Okay.
We have just now been able to get that vision to reality imperfectly, patchy, and in a limited way. And with a couple of tribes, there's an epic tribe and a non-epic tribe and a we don't really care, wake us when the shouting's over tribe. And each of those tribes, well, the first 2 tribes can sort of do their thing, and the third tribe is going to get this done when they're poked into it. The policy window moved to patient-controlled data exchange, and the notion of the patient being able to access, the person being able to access his or her record following the mint.com model. And I gave you a brief synopsis of how the policy window for that opened in 2010. And the vision was lined out. Todd Park, who was at that meeting,
Todd Park, yes.
moved heaven and earth to get CMS and VA to enable download of records. We had a bunch of systems that were doing download of records. One of the things we learned is that unlike in mint.com, where Mint worked on the financial services organizations opening up records any which way, and then Mint on the back end figured out how to go get the data, it wasn't sufficient for healthcare. And so we learned that we needed to do more structured APIs, focus on data normalization, and focus on the same kinds of mechanisms that you have in Twitter and Facebook to be able to type in your password and delegate access to a new organization. Now we've got the picture of the real world of your Apple device that can go pull down data from 40 health systems. We need to make that ubiquitous.
So therefore, the notion of interoperability changed from what to what over that span?
It changed from showing providers the access to their record or to a patient's record across multiple settings of care, one patient, one setting of care across multiple settings of care. Next window was about showing the patient access to his or her record. The third window that's opening right now is aligned around accountable care, population health, and risk-bearing organizations. It's a little disappointing for this room to think about that policy window opening now, and also to think about if I give you the example of 2010 to 2018 in terms of personal access, we're starting the policy window now. It's probably going to be 2024 by the time that you all have access to clinical data that can stream out of EHRs in a simple and easy way to drive population
That's
health.
why you said before, there's a longer window.
I
than-
start thinking about 3 to 6 year windows,
Ah.
exactly.
That's what it means. Okay, good, thank you.
Yep.
Edwin, interoperability, how has that notion changed or evolved?
Our company is only 4 years old, so not, I think it's been, we have been, feel like we're pulling from the market in terms of what's, trying to create things that didn't exist before around
Yeah.
interoperability. So we get, ADT information from HIEs in hospitals to know when a patient was, left the hospital or went to the ED. We get their EHR data, usually in the form of CCDA. Which is interesting when you talk about a 3 to 6 year cycle. The tech that will change in a 3 to 6 year cycle these days is pretty substantial. So when you try to, when you're trying to figure out where the puck is going, it can make it hard to plan or to, by the time you ship something, the tech is obsolete or on an old standard. But
So
anyway,
there's a disconnect between the rate of change in tech vis-a-vis policy, right?
Sure.
They're done much different cycles.
Sure, sure. And then adoption. I
Oh,
mean,
let
so
alone
where we
adoption.
live, where we live is the land war, right? Of, hundreds of thousands of physicians out there, who are just, starting to manage their EHR situation, thinking about that clinically. And now we're saying, hey, you need to start thinking about, now the shift from fee-for-service to value-based care.
Right.
And it's a really hard, so the tools that they have are all basically firmly rooted in fee-for-service. A lot of EHRs come out of, billing system mindsets.
Right.
So, and a lot of the medical record documentation standards are also driven that way. So it forces the design of the EHRs to be a lot around fee-for-service. Anyway, so we also, we get claims as well. So we get claims from payers, obviously. We also get pre-adjudicated claims from our practice, so we know kind of how they're coding in real time. And despite all the talk about clinical data, when you're in a risk contract, how do payers look at you? Claims, right? So there's no, you can put stuff in the CCDA, and that's helpful, but we use it more for surveillance and other things to drive population health or to prioritize patients or that kind of thing. But it doesn't matter what the problem list in the EHR says. It matters what diagnoses you put on the claim. So we're always kind of surveilling across all these data sets. What are the differences? Where are the opportunities? What's missing? And because we can get an ADT feed from a HIE and find all kinds of holes in it when we get the claims back and see that there was an ED visit, but it never showed up in the ADT feed. And why is that? Well, it could have broken in 5 places.
So even today, though, interoperability is still kind of the Swiss cheese of communication.
Totally.
There's so many holes and gaps in it.
It's a patchwork quilt. So,
At best.
and so there could be things at the workflow level. There could be things in the tech. There could be things in the data,
Right.
or our understanding of the data. And there's
Right.
the standards of how many disposition codes do you have? Do they change for every hospital? That kind of stuff. So so we're kind of in this boots in the ground mode. I think there's a lot of great things going on, but we're definitely in that like what do we have today that we can cobble together and use?
And you're really working with people that are perhaps on the edge of desperation. If they're primary care docs, independent docs largely, and they're just now ramping up, they're in a much different place than, say, where some of the large integrated delivery networks are, for example, I would imagine.
I think that's fair. They're in a good place in terms of like this is much more aligned with how they want to practice medicine and things like that.
So they have come to that point.
Yeah,
Okay.
and they want to do this, and they, and we actually use data to, recruit physicians as well, and to kind of identify physicians who may be high potential for this, and usually when we walk in their office, they're like, oh God, I've been waiting for someone like you to show up, So there's a very high demand. They want to do this. They want to do the right thing.
It's nice to be an IT guy who's actually welcomed into a physician's practice. It
Well,
seems
yeah, I haven't told you about our app, but anyway, but yeah, So,
Okay.
go ahead.
Taylor, back to you. So you're doing this brand new cool thing. Do you have any notion yet at all that it's working, that it's having an impact? And if so, can you share with us how?
Yeah, so on multiple levels. So again, if our true north is proving that the person got there, did they get the service or not?
Yeah.
We can see that across a host of different service categories: education, employment, housing, legal, finance, and then subcategories. So housing, you might have permanent housing, temporary housing, emergency shelter, things of that nature, and we can get down to that patient level.
Yeah.
Across
So you can count successes.
across the board. And so since we built our architecture around the patient, we can travel with them. So if they leave San Diego and go to San Antonio and then end up in New York, I can see that longitudinal journey, and then we're just giving permission keys on who can see what. So I can see now a holistic view of an individual rather than how most social determinants of health things are, or how many people are in employment or legal or housing. I care more about how many programs does Taylor need, and then I aggregate that data.
Okay, so this is really important for at least me to understand, and maybe you'll have to draw a picture later on, but when you first explained this, I pictured connections between different sorts of social service and healthcare agencies. Like you come on with what I now know is software, and I figured you're kind of hooking them all up. But then you're also just saying that it's built around the patient. Please explain how.
It's built around the patient's data. So I'm
Okay.
connecting all of the organizations to each other.
Yes.
So now as that patient moves through this network and is connecting to different
can follow
services,
them.
they're all adding whatever they're learning to that patient's record. And so they all have access to it. So think of a Google Doc, and if we all had a Google Doc, we're all going to add some components to it, but in a more secure, HIPAA compliant,
Yeah.
FERPS, FIPA, you pick your security
We should
acronym.
hope so.
We're connecting all these organizations together and then giving them permissions on what they can see. So that gives me one patient record, whereas other systems will have difficulty because they build them in silos.
Right.
So I might have 10 networks across the country, but I might have 10 different patient records for that person.
So as a patient hits any one or more of those agencies,
Yeah.
data are being collected, identifiable to that patient.
Yep.
And there is, in one electronic location or spread over multiple electronic locations, a full profile record on a per patient basis.
So there'll be one, so we're cloud-based,
Yes.
the Unite Us platform.
Okay.
But if we need to push that information, it can go into those systems of record where it needs to go. But the platform itself is built to be connected into existing infrastructures.
Got it. Okay. Quite a novel concept. So, Arien, then back to you. What is it that you're sort of adding that is showing an impact? Can you point to anything and say, Change Healthcare has pulled this thing off? It's
Sure.
accomplished. What is that?
I can give you a ton of examples. One of the most interesting things that we're doing right now is, and this is the topic of umpteen thousand conferences that's more aspirational. We're doing some really interesting things with AI and ML, but what we're doing is
Artificial intelligence and
machine learning. But what we're doing is not the holy grail of replacing the physician and having the computer do everything for you. Instead, what we're doing is trying to automate a lot of the routine activities of healthcare and try to up-level and have people work at the top of their license. So any of these activities in healthcare where we're paying somebody minimum wage to manage coding processes for that, for example, are activities that we can replace and do much better with a machine learning based approach. So as an example, we just completed a project where we looked at EMS coding and taking the dictated narration and driving the appropriate coding standards. We've got other work where we look at risk-based auditing, and we're driving work to be able to identify which records are better to pull, for example, for a risk-based contract, where there might be some improper coding or some insufficient coding in order to drive processes.
So you're automating some of these processes.
Correct.
Freeing up people to do bigger and better things?
Bigger and better things, work at the top of their license. And then just connecting this back to the ACO agenda, I agree with Edwin that a lot of the state of the art these days is in using claims data, and a lot of the use of claims data that we've seen be very successful is in driving towards reduced practice variation, and particularly the reduced unexplained practice variation. So on a imperfectly risk-adjusted basis. I don't think anybody would claim that risk adjustment is a science these days. On an admittedly imperfect risk-adjusted basis, on a panel of 50 cardiologists, why are these three an outlier, both in terms of efficiency or in terms of increased cost, and what's going on? And one of the things that we've discovered is that the data is best used to drive a conversation about practice variation more than it is used to drive differential reimbursement rates or differential adjustments. So most people use the clinical quality measures for programmatic compliance, and they use the risk-adjusted paid and pre-adjudicated claims to drive not to drive differential reimbursement or to hammer this person versus that person, but to have a good, honest conversation about what's driving practice variation, and if there are ways to drive equivalent quality or improved quality care at lower cost.
So sort of back to the person-to-person interaction, instead of just saying, we're going to use the data to crank through and decide who gets paid how much, you're saying, hey, take a look at this. Here's a distribution of practice. You're over here.
Right.
Let's discuss.
Is there something going on with your everyone's panel is sicker,
right?
Et cetera, et cetera, et cetera. But then you can have a conversation that says, well, why do these two patient populations that look on paper to be relatively similar, why do you use imaging more intensively than your peer who's managing pretty much the same cohort of patients and managing them at pretty much the same level of quality? And then you get the two doctors talking about that, first yelling and then talking, and you actually drive down practice variation.
And then you actually do see a narrowing of the curve.
Absolutely.
And reduction in outliers.
Yep.
So Edwin, you can barely contain yourself.
I'm just laughing. Well, I'm just laughing because I know why the cardiologists are outliers. I mean, they're one of them is employed by the hospital and is sending them to a place where they can charge facility fees. I mean, it's just, so yeah, you can use the data. That's just one probably brief example, but yeah, I mean, this is. Sorry, I didn't mean to. I was just kind of busting over here because
you were, man.
Yeah, I mean, we do scorecard our specialists. This is where the primary care doc who has the incentives to do the right thing and is not encumbered by conflicted interests can just say, oh, well, this cardiologist is high value, which means that they have high quality and they also are cost efficient, and they let me know what's going on with my patient. They don't hold on to them too long. They don't send them to 10 other subspecialists, and then they let me know what's going on, right? And they don't over-test and that kind of thing. So those are, and so we scorecard that and we can give them the data to show that. So none of that happens without some level of interoperability around all these tools. I mean, you can't do this. I mean, you don't even know who a high priority patient is, a high risk patient, without some level of analytics, based on the data.
So in your brief 4 years, are you able to point to some successes insofar as how you've interacted with these independent docs and really accomplished something?
Yeah, quite a bit. And this is not, again, we're not a software company. This is not something that we do solely with technology, but the technology gives us some visibility to what's going on. Right. But we've shown, first of all, the biggest thing is we spread this across 22 ACOs and we've shown consistent results. So we've been able, we can walk into pretty much any doctor's office and get some improvement across the basic competencies that we care about, like hospital utilization or risk coding, risk adjustment, transitions of care, and various clinical and quality measures and so on. So we've reduced hospitalizations by 10% consistently across the board. We've reduced readmissions by 15 to 20% across the board.
What leverages those very important, impressive reductions? The feedback. The intel, what does it?
It's all the above. So first of all, it starts with who went to the hospital.
Yeah.
And some docs have access to this today. The HIE has a portal they can go into, but why would they go into it without the why, right? But assuming they do, and they're really, then the first thing is knowing that your patient, came out of the hospital. Did you call them within 48 hours? Did you see them within 14 days? And it turns out, even in fee-for-service, you can get paid for that. So there's sort of a good fee-for-service that sort of helps you bridge to value-based care, things like wellness visits, things like transition care, things like chronic care management. So we leverage those things, but it's not just a check the box sort of cash register thing. It's like actually do care management and drive, improve patients' lives and drive down costs. So we get those results by a combination of getting the data, knowing who the patients are, coaching the practices on it, which is no small effort, doing the change management and transformation efforts there, and then measuring that and seeing who's winning and who's not. And as you know, docs are highly competitive. So if they know that their percentile on these things is low, then they're going to change. And then they will also have difficult conversations with specialists in their community, folks that they know, and they'll be like, we need to change this, right?
So these are like basic human behavioral aspects. You're providing the data, the documentation to sort of prompt them to do what people do when they get information about other human beings.
And it's rarely hardball. It's mostly just having the conversation, like he said.
That's what Arien said. It surprised me. I thought you guys were going to go in the opposite direction. But you're just saying, give it to them, let them talk about it, right?
Yeah, there's been, obviously, one man, as I've always said in healthcare, one man's waste is another man's revenue, right? But given that the pie's got to get smaller and that these changes are coming and they know it's inevitable, we see a lot of appetite from specialists to understand how they win in this world as well.
Wow. So, Taylor, I was thinking back to our social determinants of health conversation with Rachel Carter and Karen and so forth. Looks like you're starting to hook up these services. It's patient-centered, which is really impressive. Are you still optimistic, though, that even though you've sort of connected these services, that you can have a meaningful impact on those social determinants that really drive important healthcare outcomes? And these social determinants like infant mortality, maternal mortality, lifespan, really large components of quality of life. These are not little incremental changes in my LDL level, Right. These are a big deal. So are you optimistic that this sort of intervention is going to have the potential to hit those accomplishments?
I'm optimistic that it can.
Yes.
I'm less optimistic that CMS and healthcare will allow us to get there.
Okay, so because now you're presaging what I was going to ask next, which is what's getting in the way?
I think when I look at CMS and specifically the AHC initiative that they have rolling out.
Remind people what that is.
So accountable health communities, where they set these standards where they want to screen 75,000 folks for social determinants. The problem is they're not focused on outcomes. And so we're putting solutions in place that will suffice the government's request, but long term won't get us to the point where we can have all these little outputs around the social determinants of health that then get to the outcomes that you're talking about in the sense of infant mortality rate. Am I improving someone's economic ability? And I'm optimistic because we see within the communities where we're at that it works. We're allowing, and goes back to the conversation between clinical providers, we're also seeing it between non-clinical providers. So if I'm intervening in someone that needs assistance with housing and let's say employment, and they're in Charlotte, North Carolina, and I find them housing on the north side and employment on the south side, now I've created a logistical issue. Now there's a transportation need.
Right away.
Within our software, you allow these organizations to work together, identify that problem, and then correct in real time. And so I'm optimistic that we can intervene and have the data where we can identify and put people on a different path. I'm less optimistic that we'll be able to put the systems in place that'll allow us to get there. Because if we're not thinking about the outcomes, then we're just looking at how many searches were made for certain services.
Which are easy to count.
Well, it's easy to build. It's easy to build a resource directory, put it on a map, and say that I have a solution. It's much harder to go into a community, find a housing provider, and say, here's a tool that's going to allow you to help better serve the clients, because they don't call them patients, that you're serving.
That's right.
And also make referrals, because most of these folks are going to have co-occurring needs. And so without that data set, it's going to be very hard for us to move the needle And I'm optimistic when I see DPP programs, because we have DPP providers that are using our system.
Define that.
Diabetes prevention programs. So it was talked about on the last panel. They're using our system because they're finding individuals that are going through these year-long programs to connect with other services. I'm optimistic because those models, I believe, will work where we can pay for those types of interventions. You know, it was also mentioned an AC unit instead of, you know, having this person come back into the health system. Like, we're seeing it work. It's just the adoption and making sure people are thinking about the entire workflow and not just for their organization, but who else is this individual connecting to?
Got it.
And am I providing value?
Got it. By the way, we'd be glad to take questions and comments from you at any point, and we'll have our roving microphone is somewhere in the neighborhood. And so if somebody's got a question about that, any of this, we'll be glad to take it. Arien, from what you've heard from the gentleman on your right and your left, because I think you have such a good longitudinal perspective, again, starting with your Ankh days, if not before, are we positioned, are we poised to be able to take our primary care docs and a new form of interoperability across different types of services to actually have an impact on those essential health indicators? You and I did not talk about that before today, of course.
It's a great question.
And
it's a great question.
Yeah.
So I think I'm going to connect the last panel to this panel.
Proceed, yeah.
Part of the issue that we face is that the software, the systems that physicians use and hospitals use to manage their patients are by and large engineered to do better documentation and capture for a fee-for-service environment.
Still,
Absolutely. And if you go back to the dialogue pre-EHRs, physicians, when they complained, often complained about, particularly primary care, would complain about the value of the care that they provide. But they'd also complain that they were providing service at a level 3 charge, but being paid at a level 1, right? Now, EHRs are fantastic about documenting everything that's required for a level 3 or a level 4 visit, making sure that every one of those documentation elements maps up against the E&M coding guidance. They're brilliant at it. Does that improve clinical quality? Does that improve clinical care? Not a bit, right? So the data that we get out of EHRs is also defined by those E&M coding guidance or the procedural coding guidance. Are those the data elements that we need in order to improve and appropriately risk manage and improve quality? Or are those the data elements that are required to address social determinants of health? By and large, no.
they are not, because the fee-for-service system never ran on outcomes.
Never ran on outcomes. The documentation that's required is somewhat irrelevant to the needs of longitudinal patient care, because the billing codes that are required to enter into the system bear only a passing resemblance to what's actually clinically going on. In many cases, what a physician does, what a physician orders, is a better guide to what's going on with the patient than what's documented either from a claiming perspective or in a problem list. Does a patient have diabetes? I'm better off looking at prescriptions for metformin than I am looking at documentation that's been entered into an EHR. So there is a lagging problem that the EHRs that are still being developed, used, and installed in physician practices and hospitals are being developed still for I love the metaphor of, our systems are are in one canoe, and they're not in two canoes. They're in one canoe, and they're kind of looking over at the other canoe.
We had a 90% and a 10%.
90%. So the EHRs and that are being used to collect data are being built around those 90% use cases. We can improve interoperability all day long, but we're still going to be limited in terms of the kinds of data that we get out. The second point is just going back to my perspective that we need to think in 6-year cycles. So in 6 years, it will be possible and routine to be able to collect and extract a population export of data from EHRs in order to drive risk adjustment and clinical quality measurement and clinical quality management. What I'm worried about, so first of all, it doesn't help Edwin, it doesn't help Farzad, it doesn't help Matt right now, help their physicians manage care today, it doesn't help the folks who are here manage care today. But in 6 years, are we going to have the data that we need to appropriately manage care? And then the last dimension of this is changing physician practice patterns and changing how physicians think about their job, because the dialogue right now about clinical quality measurement is that it angers physicians that they've got to go enter this thing that's outside of their normal documentation.
They get really
practice.
irritated about that.
Really irritated, and it's outside of the normal documentation practice. It's disconnected from how they get paid. So the more stuff we ask physicians to enter, the grumpier they get, and particularly the more stuff we ask physicians to enter that's disconnected either from appropriate management of patient care or from how they get paid, the grumpier they're going to get. And the data at the end of the day is only as good as what the physician enters. I think that's the emerging nexus of policy. I know that Seema Verna's talked about, Secretary Azar have talked about reforming E&M coding guidance. We've tried that a bunch of times. It always generates howls of protest. But those are the kinds of things from a policy perspective that we need to start working on in order to get to the information technology systems driven by interoperability that actually improve population outcomes,
right,
and improve the true meaningful outcomes for patients, like infant mortality,
so that's
life expectancy.
That's an insightful set of observations, and I can see how they can sort of converge on some sort of improvement. Questions, comments from anyone? I see, kind of have light in my eye here. Dennis, you don't have a question or comment?
But interoperability is so fascinating.
Yes,
You guys should be jumping up and down.
Okay.
Not in a coma yet.
First row here, please. We're going to hustle with the microphone. Thank you very much. Gentleman in the first row. And I know you've introduced yourself, but please do so again, name and affiliation.
Hi, Chris Crowley from West Health. I was curious about the more recent changes in the legislative landscape. I know that we talked about how interoperability has been explored and it's kind of come along in fits and starts. What does the newer legislation do in terms of making it more imperative for HHS to actually kind of force a solution?
Is the foot on the gas or coming off the gas?
I think we're talking about 21st century cures. And one of the interesting things about 21st century cures is that HIPAA historically has allowed information to be exchanged, but there has been no mandate to exchange information. 21st century cures places an affirmative obligation on providers, and providers in the Public Health Act is very broadly defined, I think surprisingly broadly defined, of providers of care to not information block, which is defined as enabling access, exchange, and use of clinical information for a broad set of permitted purposes. We don't yet know what the enabling regulation and enforcement mechanisms for that will be, but EHR vendors, technology vendors, have a pretty significant penalty. If there's a significant penalty on the provider side, we're going to start to see the compliance engines of these organizations gear up into motion to avoid both the financial penalties and the reputational penalties of being an information blocker. That's certainly going to help. Now, again, the question I was asking is, we can get information to flow all day long. Is it useful? Does it improve care? That's probably the next window. But 21st century cure is absolutely is an important tool in unlocking data.
And is there anything other than 21st century cures that's on the horizon legislatively that we know about that might have any impact here? I don't know that there is at this point. Yeah. And who knows with the Congress where this could go or not. Dennis, name and affiliation yet again, sir.
So Cliff dared me, I'll ask another question. Dennis Scanlon. Maybe I'll aim this at Taylor, but others may want to comment as well. So I'm wondering if, if you think about predictive modeling from a traditional claims data set, which lots of plans and others are doing, have you thought about or have you done any predictive modeling kind of with your, what you're doing? And actually to connect this back to prior discussions, if so, you could imagine how there could be some actuarial value to thinking about the value of connecting the dots like your app is doing, such that you could do projections around the what ifs. What if we invested more in this stuff? What would be the actuarial consequences? So I'm curious as to whether you've done any of that.
So yeah, I mean, we have, and we're looking at correlations within service requests as well. So how many people that walk in needing assistance with housing also need assistance with, some second and third order need. And we're seeing local governments and other organizations using this data to go in and affect policy at a local level, not at a federal level, but looking for additional funding mechanisms because they're showing that a program is now actually working by connecting these dots. I think once you start talking about, it might be a little bit too soon for, I think, AI in the social determinants of health space. And if you're talking to social determinants of health vendors and they say that they have AI, they probably don't know the difference between AI and an algorithm, and I would ask. Because you need a lot of data for the machine to start learning and for them to start making decisions. I think we'll get to that point, and we have a lot of data that we're sitting on, and we're starting to play around with some of those things, but you need a lot of repetitions for the machine to start learning and identifying that. But we're doing a lot of hand jamming on our own and looking at these service requests into particular year groups and things of that nature. So I only see that increasing, where now we can start to get in and instead of using old solutions to say, okay, this person may be at risk, or even looking at AHC's screening tool, which isn't necessarily going to get you that person to the right service that is the best fit. I think we're going to be able to leverage some of those data sets and trends to affect screening tools within local communities.
Great. Any final question before I have a closing question for our panelists here? Okay, let's start with Edwin and go audience right to left with this. So, similar question for all three of you. Each of you, as we noted at the outset and as you have reinforced very clearly in our discussion, has responded to an emerging market need. You are working at filling, in a novel way, an important market niche. Edwin, where do you want to go next? So you've built up this 4-year experience with your outfit, and you're working with the independent docs and so forth and making progress, but what's going to be your next attempt at doing something at a higher level, or the next stage, Edwin?
There's maybe keep it just interoperability, I guess, yes. But I mean, there's two things. The data blocking is real. We see it all. We have trouble getting data, so that's just like out of the box, the first thing that...
Data blocking? I'm sorry.
Yeah, so what Arien was talking about with legislation, hospitals hold on to data. So they don't want to share data with the community to, honestly, for various reasons. So okay. So we struggle to get those connections. Some states are better than others, some markets are better than others. And so just being able to have data flow in the community in general is a start. Specifically with the EHR, I agree with everything that was said around. EHRs are like I said, firmly rooted in fee-for-service, which means, and so we have enough trouble getting data out of EHRs. At Aledade, we connect to 40-something EHR vendors in our universe. It's really horrendous, and we're pulling data, so it's only one way right now.
Yeah.
So try pushing data into a workflow in an EHR. That's happening a little bit with some vendors, but again, because they're not population health, not value-based care centered, that stuff just, that should be my next startup. It just doesn't, it just doesn't exist. They're so transactional.
So what you want to do next is
Push data at least into the workflow of the EHR. We have an app today that augments their EHR to do these things, but a lot of those workflows would be best done directly in the EHR. Like it's just, who are my high priority patients? Who are the patients I need to call today? What are the coding gaps that I see? All kinds of things.
You want to make it bi-directional.
Yes.
Okay.
So push it, but not just the data, but also the workflow, so that they can push that way.
Workflows, well, got it, good. Arien, where do you want to take it next?
I'm going to two different directions. One is off 21st Century Cures and some work that ONC is doing around TEFCA, make the interoperability that we've defined in Commonwealth much more broadly and ubiquitously available. So at least that basic need of physicians seeing the patient is in front of them and the records across multiple settings of care more broadly defined is thing one. Thing two is that we do 12 billion eligibility, claiming, and remittance messages a year.
12 billion?
Billion with a B. There's a lot of value in that data. So the work that we're doing right now, and the work that I'm doing and focusing on, is making sure that all of that data that comes out of, or that gets transacted, is available for the patient, the provider, the system, the payer, to improve care delivery, and care efficiency.
So really open up windows to all those decision makers, right?
Those are, didn't mean to interrupt. Those are vectors into the workflow, right?
right.
So they have an established process for eligibility today, but now it could be made much more valuable with additional data because there's several wedges like that into the practice that you could take, or into the provider.
But vectors into all those.
Yep.
Point very well taken, thank you. Taylor, you've already done some innovative stuff, but what's your next?
I think it's now about expansion. So we have scale today in our 38 communities where they're connecting. But I see the market looking at populations. But care is delivered locally, be it health, human, or social service. And so what we're building is the infrastructure within these communities where, regardless of the population, veterans, Medicaid, opioid, youth development, you name it, they're all connecting into the same service providers, and building the infrastructure where these communities are now on par with their healthcare counterparts from a technology sense, and really focusing in where we can connect the dots now, where right now they're still using pen, paper, and phone calls and emails.
So the rising tide will lift all boats to the same level.
That's it.
That is ambitious. But good gosh, I'm just going back to our first panel, how challenging those social determinants of health have been. Intractable is probably the best way to say it until now. But maybe we've got a way to get into the services that can be responsive to those in a more integrated fashion.
And tech is just a piece.
Just a piece.
So we are not a silver bullet. We are a tool that connects humans to humans. And I think technology vendors need to realize that you are a piece of the puzzle, albeit a critical piece. You are not the silver bullet.
Got it. Well, maybe Rachel, you can talk to Rachel after this. She seems like she's one great in need of all that stuff, and a well of enthusiasm as well, which is what's called for here. So I got to say that I thought I knew a little bit about interoperability, but I didn't realize how little I truly knew until I interacted with these three guys, because, as I said, they're all doing something really new, and they're meeting these unmet needs. And I'm also impressed that they're all also kind of thinking about the next stage of what can be accomplished in what is otherwise a very trying area. Who hasn't complained about interoperability? Everyone has complained about it, but I applaud them for their initiative and their willingness to stick to one of the most difficult issues we've got today with measured success. So with that, Taylor, Arien, Edwin, thank you very much. Great input.